Good morning, everyone. I'm Dr. Hrishikesh. I'll be presenting a case presentation. Here we have a patient who is a 46-year-old male. He's nursing staff by profession and resident of Kota, Rajasthan. He came. He presented to us with complaints of passing multiple episodes of black stools over past 1 month. Patient had history of multiple passing multiple episodes of dark stools over last 1 month. Stools were foul smelling and had he had increased frequency of stool, and it was when he was passing the stool, there was no associated pain abdomen along with the passing of dark stools. The It was also associated with fall in hemoglobin levels, which was monitored by routine lab tests and which required multiple blood transfusion over a period of 1 month. For this, he underwent upper GI scopy and band ligation uh, in the first week of the symptom, and it was also associated with the loss of appetite. Uh, he He had no history of vomiting or hematemesis. He had no history of abdominal distension currently. He had no history of altered consciousness or drowsiness, and had no history of loose stools or constipation, that is, altered bowel habits. And he had no history of fresh perrectal bleed, and also no history of loss of weight over a period of 1 to 2 months, and also no history of pruritus currently. In the past, he had a history of jaundice, which was 8 months back, which had resolved at that time only. That jaundice was acute in onset. It was gradually progressive over a period of 1 month, and it over a period of 15 days, and it was associated with clay-colored stools. And he was diagnosed to have uh, CBD stones, and he was managed with clearance of those stones in July of 2024. In between, he was asymptomatic, but he had 2 episodes of fever and was diagnosed with stent block cholangitis, and this stent was exchanged twice. He has no other comorbidities. He has no past surgical history. He is a vegetarian. He follows a vegetarian diet, and he has no habits, and his bowel habits were regular. And the for the treatment history, he underwent EVL band ligation 1 month back, ERCP stone clearance stenting 8 months back, and twice stent exchange over a period of last 8 months. He had no significant family history. So to summarize, here is a 46-year-old male who is history of with a history of recurrent melena for 1 month, and managed with upper GI endoscopy and band ligation of varices with loss of appetite, and a past history of surgical obstructive jaundice, diagnosed as CBD stones, and ERC clearance was done.
As soon as the patient says this to you in the OPD, what comes to your mind?
Sir, history of melena, upper GI bleed.
So you think this is what is Alina?
Melena is passing of dark tarry stools and foul smelling dark tarry stools, which points towards ongoing upper GI bleed.
So it is dark black, tarry,
Sticking to the pan in
foul
case.
smelling
Yes.
stool. So why, if it is foul smelling and sticky, why is this not steatorrhea?
Sir, the color of the stool, it is dark,
Yes.
so it points towards the degradation of hemoglobin, which is in the intraluminal compartment.
So steatorrhea stools will be yellow in color. They will not be dark in color.
Yes.
Eh?
And along steatorrhea too will be greasy and difficult to flush.
You can even see flat globules if it is very severe steatorrhea when the stool
हजुरले बनाउनुहुन्छ नि काउली सुकाएर अचार त्यस्तो बनाउन आउँदैन
whether any
कस्तो मिठो बनाउनुहुन्छ नि
seen. Any other difference between steatorrhea and steatorrhea stools are usually large, bulky. Melina stools will not be large. They will be normal quantity. Okay.
Yes.
So steatorrhea is basically frequent passage of large, bulky, foul-smelling, frothy, sticky stool, which is normal in color, and sometimes even fat globules may be seen. On the other hand, melena is normal amount. It may be slightly increased depending on the quantum of blood. There may be frequency of passage because stool causes hyperperistalsis.
Yes.
So the frequency may have increased, but it is not as high as in steatorrhea. And it is black, dark black in color. It may be foul smelling, it may be sticky. What do you mean by upper GI bleed?
Bleed, bleeding, intraluminal bleeding before ligament of treats is termed to be upper GI bleeding.
So you mean to say that bleeding below the upper ligament of treats cannot cause melena?
Sir, it can cause melena if there is slow transit time of the stool, and if the hemoglobin is degraded during the intraluminal path.
So how does small bowel bleed present?
Small bowel bleed can also present with melena.
Yeah,
Usually
even
more
with normal, you said if there is a slow transit, even with normal transits, small bowel bleed will also present as melena. So melena includes both upper GI bleed and small bowel bleed.
Yes.
Even patients who have an ileocecal lesion or a right colonic lesion, they may have, they may say that they are passing dark stools. So it is not only upper GI bleed. Melena indicates upper GI and small bowel bleed. So when the patient gives this history, what comes to your mind? When you have located the site of bleed, that it is either upper GI or small bowel. What about the pathology? What are you thinking?
First, different causes of first will have differential of upper GI bleed causes. That is either a peptic ulcer bleed, which should be most of the time the first diagnosis, and can be malignant bleed also, and also can be due to the varices.
So which is more common, malignancy or varices?
Malignancy, varices is more common than
the three common causes of upper GI bleed are peptic ulcer, varices, and even gastritis, you can say, but then we will discuss that why it is not gastritis, and then malignancy. So out of these possible causes, which is more likely in this case?
After the history, sir. After
okay, let's go on.
Yes.
So other than these upper GI, what about the other causes of melena?
Yes, sir. Like as said earlier, small bowel bleed.
So what are the possible causes in the small bowel which you have to keep in mind?
In small bowel can be enteritis, gastroenteritis causing bleed in the small bowel, and also although
gastroenteritis doesn't cause so much bleed that it causes melena which is persisting for a month.
Yes, sir. Although rare, but small bowel malignancy can also cause.
So you have to think of inflammatory diseases of the small bowel, not infective, inflammatory.
Yes, sir. Like Crohn's disease.
Crohn's, tuberculosis. You have to think of small bowel malignancy.
Yes, sir.
So you have to keep all these possibilities in mind because that is when, or that will decide what direct leading questions you will ask. Okay. So based on the details of the history, this
sir, more.
Let us forget the history of upper GI endoscopy and band ligation. Now, what do you think?
More likely, if we remove that, can be more likely due to malignancies.
Which malignancy? Where?
CA stomach.
Okay.
Can be CA stomach or a duodenal adenocarcinoma.
Why do you say duodenal?
Because it is more common than the small bowel malignancy, and also it is usually associated with jaundice.
So, but
There was history of jaundice which was relieved
that
on.
is past. That is, we know it is CBD stones. So I don't think you should say duodenal adenocarcinoma unless you have features of gastric outlet obstruction. CA stomach can be there with just bleeding and no dysphagia or no gastric outlet obstruction. But duodenal carcinoma clinical diagnosis should be made only when patient has gastric outlet obstruction, maybe with bleed, maybe with jaundice, depending on the location of the tumor. Otherwise, you should not make a clinical diagnosis of duodenal carcinoma.
Yes, sir.
Any other lesion which can just cause bleeding? Which you haven't mentioned so far?
Delphi lesion can cause.
Those are rare diagnoses. Those are basically endoscopic diagnoses. Any other tumor?
Gist.
You have to keep gist in mind. Although again, you make a clinical diagnosis of gist only when you have bleeding and a lump. If you have just bleeding, you keep it as a possibility, but you don't diagnose that this is gist. What about the loss of appetite? He says that he has lost his appetite.
When there is blood in the bowel, it causes inflammatory changes in the bowel, and there is loss of appetite in response to that. And he will feel fullness, and he feel like gastroenteritis related.
I don't know whether blood in the bowel causes inflammation. It just causes stimulation of the bowel peristalsis. And I don't think there's any relationship between GI bleed and anorexia. So what I'm trying to hint that since patient does complain of anorexia, you have to consider malignancy as a possibility. And in a patient who has GI bleed and anorexia, middle-aged gentleman, you have to keep CA stomach as a strong possibility based on this history alone. Then you can say that it could be small bowel malignancy, but small bowel malignancies are not common, so you would not like to make a clinical diagnosis of a small bowel malignancy. Yes. Next.
He can directly speak, sir, cheap complaint history of melena for 1 month in place of multiple episodes of black color stool for 1 month. Can he?
Medical.
Yeah, it's okay. I mean, as I keep saying again and again, it depends on the examiner. At MCH level, I accept some of these interpretations, but some examiners are very finicky. They said, did the patient tell you that I am having melena? Why did you say? So some examiners insist that you describe the history as it was told by the patient rather than your interpretation. So that is why I keep pointing this out. Because it unnecessarily generates a discussion. Okay. It is pruritus, not pruritis. Yes. This is a very commonly misspelled medical term. Yes. Next. So we know that he had CBD stones. How do you relate these two events?
Sir, these two can be related if these CBD stones were primary CBD stones, which can be caused due to cholestasis and also can be due to any biliary pathology on basis of history, because upper GI bleed is due to varices that we know because he had underwent variceal ligation, and it can be so two differentials can be a cirrhotic portal hypertension or a non-cirrhotic portal hypertension. And if they are non-cirrhotic, there is usually portal biliopathy associated with that. So that can cause primary CBD stones.
Yeah, so you should say that one way I can explain this is that the patient has extrahepatic portal venous obstruction, which resulted in variceal bleed and which also caused portal biliopathy or portal cavernomatous cholangiopathy, as it is now called, which resulted in biliary obstruction and primary CBD stone formation. That is one explanation. Second,
can be due to blood loss and hemolysis. Blood loss
will cause hemolysis.
No, blood loss and
any other way that CBD stones can be caused. One is portal biliopathy. In a patient with portal hypertension, suppose we say that yes, he has varices, he has variceal bleed. Any other way that he can develop CBD stones other than portal biliopathy? So other than variceal bleed, what else patients with portal hypertension can have? They have splenomegaly, hypersplenism, excessive hemolysis, resulting in formation of pigment stones. So that is another way that you can explain. Can Can there be a reverse correlation that jaundice is the primary disease and then patient has developed portal hypertension?
Obstructive secondary biliary cirrhosis.
Yes. So patients with CBD stone, but then there should be history of recurrent episodes of cholangitis, usually long-standing CBD stone disease or any biliary obstruction, recurrent cholangitis, which usually or which can lead over a period of time to secondary biliary cirrhosis and then portal hypertension. So whenever you have jaundice and upper GI bleed, these are some ways that you can explain. Now, here we know that jaundice was because of CBD stones, but suppose that history was not there. Suppose I say that he has melena, he has anorexia, and he has jaundice.
Then if it is painless jaundice, then it goes more towards malignancy, including periampullary malignancy or duodenal, around the.
Suppose I say that it is CA stomach. Can a patient with CA stomach have jaundice?
Very rare, sir, if there is infiltration into the porta from the stomach.
How can CA stomach infiltrate? What is more likely to be infiltrated in the
Pancreas.
CBD, the intrapancreatic, but more common is nodes. Nodal spread in the hepatoduodenal ligament and porta hepatis, which can cause biliary obstruction. Second is that if it is an entropyloric growth and there is posterior infiltration into the pancreas, then the intrapancreatic part of the CBD can be involved. In fact, when we used to see long-standing, untreated or improperly treated peptic ulcer disease, peptic ulcer penetration, posterior penetration, was also one of the uncommon causes of biliary obstruction and a lower CBD stricture without a history of cholecystectomy. So one of the causes of benign biliary obstruction other than chronic pancreatitis, primary sclerosing cholangitis used to be a posteriorly penetrating peptic ulcer. Same way, an entropyloric growth can have a posterior infiltration into the head of the pancreas and can cause biliary obstruction by blocking the intrapancreatic part of the CBD. Okay, let's proceed.
One of the benign cause of this, whatever you have explained, melena with the loss of appetite and hematemesis or bleeding, the chronic liver disease can be a possibility here. Patient may have a loss of appetite, the melena
and jaundice. And yeah, so if that history of endoscopic intervention is not there, Dr. Anand says that you have to keep in mind chronic liver disease as the cause of variceal bleed, as the cause of anorexia, and the jaundice is basically medical jaundice because of chronic liver disease. It is not obstructive jaundice. So if that history of endoscopic intervention is not there, that possibility also you have to keep in mind.
Yes.
Yes.
So we have differential diagnosis. Benign causes include peptic ulcer disease and cirrhotic and non-cirrhotic causes of portal hypertension, and malignant cause based on history may be carcinoma stomach and duodenal malignancies.
Yeah, but in the benign causes, in the absence of history of pain, to say that peptic ulcer disease is the first diagnosis would be a little difficult. You should have pain if you make a clinical diagnosis of peptic ulcer disease. Variceal bleed, painless bleeding is more likely to be variceal, more likely to be GIST, more likely to be malignancy rather than peptic ulcer disease.
Yes, sir. Moving on to the general physical examination. He is an adult male, conscious, oriented, and alert. He is well nourished, well built, and well nourished, with a BMI of 20.2. He's vitally stable, and he has currently no pallor, icterus, clubbing, cyanosis, or pedal edema, and he has no features of chronic liver disease, including all the features like fetor hepaticus and loss of axilla and pubic hair, testicular atrophy, and there were no evidence of any spider nevea or telangiectasias over the world. On abdomen.
Go back. You missed a very important finding in the general physical examination. You haven't mentioned anything about the nodes in the neck. You are considering a possibility of a CA stomach.
Yes, sir. No lymphadenopathy, generalized lymphadenopathy, or
specifically left supraclavicular
lymph nodes. On abdominal examination, abdomen is flat, umbilicus central. No visible abdominal lump is seen on inspection. No visible peristalsis or pulsations. Hernial orifices were normal. On palpation, abdomen is soft and non-tender. There is mild splenomegaly, which is examined which is found to be 3 centimeter below the costal margin, and there was no hepatomegaly. On percussion, liver span was 14 centimeter in mid-clavicular line, no shifting dullness to point out towards any free fluid in the abdomen. And on auscultation, he had normal bowel sounds, and on PR examination, it was otherwise normal. There was normal anal tone, no evidence of bleed or no evidence of hemorrhoids, fissure, or fistula, and he had no melena on the PR examination. His other systemic examination were normal, including respiratory system, CVS.
So again, I say that lump which you have palpated in the left upper quadrant is the GIST.
Can be a possibility of GIST, but it is more
again,
likely to be.
Some examiners would insist that rather than saying that spleen is 3 centimeter, you say that there is a lump palpable in the left upper abdomen, which is 3 centimeter from costal margin. It moves with respiration. It is moving towards the right iliac fossa. Whether a notch is felt or not, whether it is bimanually palpable or not. So, especially if it is the first case in the exam, you should describe the examination as you would do in an MBBS exam.
Yes, sir. So to summarize, he is a 46-year-old male with recurrent melena and managed by EVL therapy, and he had past history of surgical obstructive jaundice, with status post CBD stone clearance, and abdominal examination reveals mild splenomegaly, and other systemic examination was normal.
Now, what is your diagnosis?
Sir, portal hypertension and malignancies like lump forming malignancy just can be the possibility. CS
that if you think it is spleen, then don't say just. So if examination, I was saying when you are describing, you should describe it, and then you can infer that I think it is splenomegaly, rather than straight away saying splenomegaly. And this is not the complete. You should not give just one word diagnosis. When you make a diagnosis of portal hypertension, what else you have to say? And in any case, we haven't made the complete diagnosis in this particular case.
On basis of history and examination, most probable diagnosis is portal hypertension, can be cirrhotic or a non-cirrhotic cause.
Which is more likely?
More likely towards non-cirrhotic.
Which non-cirrhotic?
EHPVO can be a cause because of splenomegaly. And
splenomegaly is not there in NCPF or cirrhosis?
Frequency is similar in NCPF and EHPVO, splenomegaly. However, the upper GI bleed, which was managed conservatively and which point towards that the liver synthetic function might be patent.
So cirrhotic bleed you cannot manage endoscopically?
Can be managed, sir, but very difficult to say between EHPVO and NCPF based on history and examination.
What are the points in history? And upper GI bleed will be present in all.
Yes,
splenomegaly will be present in all. Control by endoscopy will be present in all. Some series describe that in cirrhosis, spleen is slightly smaller. In EHPVO, it is bigger. But you can't differentiate. That is only for descriptive purposes.
Can you differentiate cirrhotic versus non-cirrhotic on the basis of history?
The first thing, bleed. Can you differentiate bleed between cirrhotic and non-cirrhotic?
History.
On the basis of history, if we talk about the bleed.
Sir, if he has multiple episodes of upper GI bleed, which are managed conservatively, which are not causing any decompensation late in the during that course, so it is more towards non-cirrhotic.
Decompensation comes first. The bleed with decompensation.
If he is having,
and then bleed with decompensation, either tolerable or intolerable bleed, like associated with hypotension, requiring any intervention.
Yes, sir.
So if a patient has significant bleed and patient doesn't decompensate, it can be there in cirrhosis also, but it points. If the patient decompensates, it is definitely cirrhosis. If even with a large bleed, the patient doesn't decompensate in the form of ascites and cephalopathy, then it points more towards non-cirrhotic or a compensated cirrhosis. What else is here which points towards EHPVO, and what is against EHPVO? What about the CVD stones? You just discussed portal biliopathy and primary CVD stone
pointing towards EHPVO.
But as we discussed that even in cirrhosis or NCPF, when there is a splenomegaly and hemolysis, but here spleen is small, 3 centimeter only. So it is not a moderate or a massive splenomegaly.
Yes, sir.
Although I don't know whether there is any correlation between splenic size and the degree of hypersplenism, because we discussed that jaundice can be because of hypersplenism. And as Dr. Anand said, jaundice can be because of CLD also. But here we know that there were CBD stones. So only two possibilities are portal biliopathy and hemolytic pigment stone formation.
Yes, sir.
The point against EHPVO here, what is the usual age of presentation?
Early to first or second decade.
It is very unusual for a 46-year-old male to first time present with variceal bleed in a patient with EHPVO. Why? Why is it so that the adults, I mean, it doesn't usually present at this age, it presents at an early stage?
Because, sir, they usually first is that EHPVO rarely decompensates. The liver functions are preserved as there are many collaterals supplying to the liver, and usually they do not bleed.
So the reason is that patients with EHPVO, over a period of time, they tend to develop extensive retroperitoneal collaterals. And that if the patient hasn't bled during childhood, adolescence, or young adult age, it is very uncommon for EHPVO. The term used by Dr. Dilavari was that the patient outgrows the portal hypertension. And in adulthood, it is very uncommon. They may present directly with portal biliopathy and jaundice and cholangitis. So age is a point which is against the clinical diagnosis of EHPVO in this case.
Yes.
But all this could still be compensated cirrhosis, causing portal hypertension, causing variceal bleed, splenomegaly. Following a massive bleed, spleen may regress to some extent in size, and hypersplenism causing CBD stones, pigment CBD stones, pigment gallstones and pigment CBD stones.
May I interrupt, sir?
I would like to further investigate the patient. His blood investigations period has been charted. His initial hemoglobin was low due to the upper GI bleed, which was 5.6, and also his liver functions were normal at that time. So he had underwent multiple blood transfusions, and currently his hemoglobin is 8.2, and his counts are 3,500 and platelets of 105. So it is a CBC picture is pointing towards blood loss and not towards any evidence of hypersplenism.
Platelet counts are low. All counts are less than 150. Total counts are normal. What is normal platelet count?
So 150 to 450.
150 to 300. This is all 120. So at least one element, there is a reduction. But isolated low platelet count can also point towards chronic liver disease.
Yes.
And his serum albumin, at least in one of the reports, is 2.7. Although later it has got corrected to 3.9. INR is normal. So INR being normal, that 2.7 may be following you should say that a young man, 46-year-old, otherwise healthy young man, coming with a hemoglobin of 5.6 points, that it has been a major blood loss. Plus, he has history of requirement of blood transfusion. So you should point that out, that he has had major blood loss. One element of the blood cells, the count is reduced, and
platelets are
low, and
on lower side.
The liver functions currently are within normal limits, but normal liver functions do not rule out cirrhosis. Compensated cirrhosis, you will have normal liver function.
Yes.
So based on this, you can't still say whether it is cirrhosis or EHPV. Only thing you can say that he has had a major blood loss and probably there is some hypersplenism.
No, it is in EHPVO that the hypoproteinemia usually occurs when there is upper GI bleed, and this hypoalbuminemia recovers after the episodes of bleed.
Yeah, so I don't know whether it is documented or not, but it has been observed that patients. Just check whether Dr. Richa has joined.
Yes.
She's there. Sorry, Richa, I forgot you are there. So please put your mic on and keep commenting in between. So Dr. Richa, for those of us who do not know her, was my colleague at SGPGI Lucknow. She's a pediatric surgeon. She probably has one of the largest experiences with surgical management of extrahepatic portal venous obstruction in the country and maybe in the world. So, Richa, please feel free to make any comments or ask any questions in between. Sorry.
Thank you, sir. Thank you very much, sir.
Can somebody respond? Can you hear me, please? Can you hear us?
Yes, sir. We can hear you.
Okay, good. So, Richa, please feel free to comment or ask any questions in
Yes,
between.
yes, sir. Thank
Sorry,
you.
I missed you earlier.
He had underwent a upper J endoscopy, which showed a grade 3 varices and with active signs of bleed. And this variceal bleeding was managed with endoscopic variceal ligation. And after that, he was hemodynamically and symptomatically better. He also had underwent ultrasound sonography abdomen, which showed absent. It was targeted sonography, not the whole abdomen. Sonography with splenoportal Doppler. So it was showing absent portal and splenic veins with formation of portal cavernoma, and there is perisplenic, perigastric, and omental collaterals present. Non-obstructive sludge with microliths within the primary biliary confluence with bilateral mild IHBRD was present. He had also cholelithiasis along with that splenomegaly and minimal ascites.
So, what do you make out of this ultrasound report?
Presence of portal cavernoma is diagnostic of EHPVO according to the Beveno 6 classification. And also, since he has uh, mild IHBRD and also sludge in the CBD with microlithiasis can point towards a portal biliopathy for portal biliopathy. And along with that, he has splenomegaly, which is in HPVO and minimal ascites.
Yeah, it could be either portal biliopathy or it could be hemolysis causing stones in the gallbladder and the CBD. What is it is difficult to differentiate.
Yes, sir.
Okay.
On basis of some.
Yes.
So later
So what would you like to do now? This is the ultrasound and upper GI endoscopy. His acute bleed has been controlled by variceal ligation. CBD stones have been tackled endoscopically. What would you do now?
Sir, we'll get imaging like CT scan to see if there are any collaterals and EHPVO to confirm the EHPVO, and also an MRCP to suggest radiological changes of portal biliopathy.
So you want both CT and MR?
MR, sir, CT is for the if there is planned surgery if there is planned surgery. Otherwise, MRCP is required initially.
Why do you need a CT for surgery?
Sir, if there is shunt surgery planned, so we need to know the site of large collaterals, or if there are any spontaneous collaterals already in the abdomen, and also the patency of the splenic vein.
So for that, you need a CT. You can't.
Yes, sir.
You can't get the same information from an MR.
MR angiography needs to be done. If
so, in this setting where you have both portal hypertension and biliary obstruction, biliary disease, what will give you the more information?
MRCP with MRI angiography.
Yeah, so the choice investigation here would be an MR imaging with MR cholangiography and MR photovenography, because you want information about the splenic vein if you are planning a shunt, and you want information about the biliary tree, whether there are collaterals ligament, whether there are collaterals around the gallbladder because he has cholelithiasis. You will need to do a cholecystectomy. CBD has already been tackled, isn't it?
Yes.
And did they demonstrate that CBD is cleared?
Yes, sir.
CBD need not be cleared. So you are looking at collaterals, and all that information can be given by one investigation rather than having to do a CT scan. Yes. CT is not an essential investigation in a case like this.
Yes, sir.
But we have a CT.
We have a CT.
Let's see. So whatever imaging you do, basically, if you are planning a surgical treatment in the form of a shunt, you want to see whether there is a splenic vein. You want to see the presence of the left kidney and the position and the anatomy of the left renal vein.
Yes. We can see in the triple phase scan, there is presence of minimal pleural effusion. Liver liver seems to be normal, and
So you should say size and surface of the liver is normal.
Yes.
Whether there is any caudate lobe hypertrophy, what is the size of the left lateral segment? Because again, it has been observed by my colleagues, Dr. Richa and Dr. Anu, that in EHPVO, in a large number of patients, the left lateral segment is atrophic. Segment of the coagulation profile. You can't show the film, give us the findings, because I would like to leave few minutes for Dr. Richa to make some comments in the end.
Yes.
Give us the CT findings, CT report. Yes.
Sir, triple phase CT shows EHPVO and cavernous transformation of portal vein. There are multiple collaterals which are peripancreatic, periportal, peribiliary, and splenorenal small collaterals and retroperitoneal collateral formation, and with lower esophageal and perigastric varices. Gallbladder shows edema with fat stranding, and IHBRD is present, which suggestive of portal cavernous cholangiopathy. Also point towards hepatosplenomegaly and presence of ascites. We have MRCP as well, sir. MRCP is showing dilated intrahepatic biliary mild dilated intrahepatic biliary radicals with dilated CBD.
Size?
This
is pre-stent or post-stent?
So this is post-stent.
Pre
this is pre-stent.
इसी का है?
Yes.
नहीं यार, next
MRCP showing dilatation of IHBR in both lobes, common hepatic duct noted up to cystic duct confluation. CBD is not dilated, stent is noted in situ. Suspicious few small filling defects noted in IHBR and common hepatic duct measuring 2 to 3 mm. Gallbladder is over-distended with presence of calculi in the GB, and with mild pericholecystic fat stranding is noted. Pancreas is normal. Liver is showing patchy areas of increased signal intensity. Spleen is enlarged with 26 centimeter with normal signal intensity. And main portal vein, superior mesenteric vein, and retropancreatic splenic vein are replaced by multiple collaterals.
Do we have an MR portovenogram? No.
No.
There was no.
They have commented only on MRI basis.
So, Richa, I would like you to make some comments on the clinical presentation which we discussed, that how to differentiate or how to say that whether it is EHPVO, especially in a 46-year-old gentleman, approach in a patient with portal hypertension, when more so we are thinking of EHPVO.
So I think the clinical differentiation part has been well discussed. So I don't have anything significant to add to it, except that maybe at 46 years of age with a short duration history of bleed, one can think of secondary HPVO with an underlying prothrombotic state and keep that in mind. That is the only thing which was coming to my mind in addition when we were discussing. I thought that at this stage, it's more important to think of the management because this is a difficult problem now. It is a situation where, as per the CT, the anatomy is not shuntable. The splenic vein as well as the superior mesenteric vein both are replaced by collaterals. And the MRCP, I would like to see it again because one would need to figure out whether these are findings of portal cavernous cholangiopathy or whether this was just CBD calculi because of hemolysis, because the management would be a little different.
These are not, sir, not this patient, sir.
Because this looks more like CBD calculi, this MRCP.
He missed.
Sorry, the image which we displayed was a wrong image.
Sir, ये एक बार WhatsApp पे दिखाया था मैं आपको. एक बार will show you the image.
नहीं तो मुझे WhatsApp करो, मैं उनको करता हूँ.
Yes, sir.
Richa, I'm going to WhatsApp you the MRCP image of this patient.
Thank you, sir.
या ये दिखा देगा screen पे. So what would be your approach when clinically we are thinking of EHPVO and the patient also has jaundice, where we start thinking that it could be portal biliopathy, as far as the investigation are concerned, whether you would do a CT and MRCP or you would do only an MR imaging?
So, sir, it all depends on the expertise of the radiology. Now, one can theoretically say that a combination of a good MR portovenogram and MRCP should give us the vascular anatomy as well as the biliary anatomy, and that single investigation should help us in deciding on the further plan of management. But a lot of times, which also happens in SGPGI, that on an MRI we are able to give the biliary anatomy nicely, but the vascular anatomy comes out to be better in CT portovenogram. So, especially in a situation like this, when we are not able to visualize the veins, the splenic vein and the superior mesenteric vein on the Doppler, and it is important that we should be able to give a shunt to the patient if the anatomy is shuntable, because that is the only thing which will help a patient of portal cavernoma cholangiopathy. We would like to do a CT portovenogram. So, does my answer make it clear that yes,
so students, I hope you got the message clear from Dr. Richa that MR would give you a better delineation of the biliary anatomy. But if MR portovenogram is not telling you or giving you enough information about the splenoportal venous anatomy, then you may have to do a CT portovenogram also. So this Richa is the real or the correct image of this patient.
So Hrishikesh, what is your interpretation on this? Because this is a very different cholangiogram as compared to what you showed earlier.
Yeah, the previous one was wrong.
Ma'am, it is showing irregularities in the ductal anatomy, like in the ductal wall, and along with that, there is mild IHBR dilatation. Along with that, there is compression, a mild compression or a narrowing of CBD.
So now can you kind of say whether this is portal cavernoma cholangiopathy or whether this is CBD calculi because of hemolysis, the two differentials that we were entertaining?
Yes, ma'am. Since CBD is not dilated along with the intrahepatic biliary radicals, it can be the whole CBD is compressed with the portal biliopathy. So point more towards portal biliopathy rather than CBD stone.
So this picture points unequivocally points towards portal cavernoma cholangiopathy. So you would agree on that?
Yeah, because CBD stones are very unlikely to cause a hilar. This is almost a hilar block. The obstruction is at the hilum. CBD stones usually will cause lower end block, and there will be dilatation of CBD. You should see intraluminal signal void in the MR cholangiogram, which we do not see. Plus, if you see the left duct, there are these indentations, which may be because of the intrahepatic collateral. See this? See here? So there are some intrahepatic indentations also, and the entire common hepatic and common bile duct is not seen, which means that it could even be, now when we talk of portal cavernomatous cholangiopathy, it could be compression by the dilated high pressure collaterals, or it could be a fibrotic stricture. Here, since we do not see multiple indentations, it is possible that the patient has already developed a long stricture of the CBD.
So the other explanation as to why we cannot see the CBD and the CHD in this picture is because there is a stent in C2. So that stent is keeping the CBD decompressed.
नहीं, but report में तो stent लिखा है. In-situ है. Yeah, stent in C2. So this probably the artifact that we are seeing is probably the stent. But Richa, my point is that if the stent has gone beyond the hilum, we don't know where the upper end of the stent is, then even the intrahepatic biliary radicals should not have been dilated. So this disproportion between the intrahepatic ducts and the right and left ducts and the CBD points more towards that it is not because of CBD stone, it is because of portal biliopathy.
Yeah. So here we have a difficult problem that we have a patient of EHPVO. It is an anatomy which is not amenable to a shunt. The patient has had symptomatic portal cavernoma cholangiopathy. There is a hilar stricture. So what further for the patient? What can we offer to this patient now? What should be the treatment plan now?
Hrishikesh, did the CT confirm that the splenic vein is not patent or not there?
CT was showing that splenic vein is patent.
So CT here showed that the splenic vein is patent.
MRI
Okay,
was
okay.
not.
Yes. Although MRI did not pick it up, but that is the point you were making, that MR is not a good investigation for the vascular anatomy. CT is a better, more objective investigation for the vascular anatomy. So since CT here showed a patent splenic vein, Hrishikesh, what would be the management plan of this patient?
So shunt surgery for the patient to manage both portal biliopathy progression and also recurrent upper GI bleed.
How would the shunt take care of the portal biliopathy?
So the collaterals towards the liver after the shunt surgery might decompress and also uh, may lead to stopping in the progression of biliopathy due to the portal cavernoma.
Yeah, so what you should say that if the biliary obstruction is only because of extrinsic compression by these pericholedochal high pressure collaterals, once we do a portosystemic shunt, the pressure in these collaterals decreases, that external compression gets relieved, and a good number of patients, the portal biliopathy may resolve without any intervention on the biliary tree. But if it persists and you wait for about 3 months or 6 months, if it persists, then you think that it is a fibrotic stricture. Richa, you would like to?
So, sir, the way I look at the further treatment plan and the further course of this patient is that uh, we hope that we'll be able to give him a good splenorenal shunt, and we would perhaps opt for a splenectomy and a central splenorenal shunt because he has hypersplenism. And 6 months or 9 months after a persistently patent shunt, we would perhaps aim at removing the stent and seeing how his liver function is behaving. So you can tell me whether you agree with me or not, because that is how one would know whether the decompression of the pericholedochal and the epicholedochal collaterals have uh, helped in relieving the obstruction on the CBD. Now, if after a persistently patent shunt for 6 to 9 months, we remove the stent and the liver functions continue to be normal and the patient does not develop any symptoms, we can, just keep the patient under observation. But if the liver functions again start showing a rise in alkaline phosphatase or GGTP or conjugated bilirubin, or the patient has biliary colic, or if the bilirubin starts rising, then we know that that shunt alone has not been sufficient to take care of his portal cavernoma cholangiopathy. Then we have to think whether we need to intervene on the biliary system to relieve his biliary obstruction. Now, whether that intervention has to be surgical or a uh, ongoing endoscopic intervention depends on the anatomy, which we will reassess on the MRCP at that point of time. Now, if we look at the MRCP at this point of time, it appears to be a hilar stricture. It doesn't seem to be a very it doesn't seem to be a situation where one can easily access this surgically in the setting of EHPVO. I mean, this kind of a hilar structure in benign, in bile duct injury, I mean, all adult GI surgeons are very comfortable taking care of. But when there is a hilar stricture in the setting of EHPVO, it is surgically a much more technically challenging point because there are lots of collaterals there. So whether we can surgically do a hepatocholectomy in case the patient has recurrent biliary symptoms after a successful shunt depends on the reassessment of the anatomy at that point of time. And so the third thing that you were saying, like patient has not had biliary colic so far, but he does have gallstones. Now, should one do a preemptive cholecystectomy in this kind of a situation or not is another thing which one needs to discuss.
Yeah, so 2 or 3 important points for the students, that both for your exam and for your clinical practice, almost never try to approach the bile duct directly without doing a systemic shunt, without decreasing the pressure in the collaterals. It is going to be very, very hazardous. You can have massive uncontrollable bleeding during surgery, which can even result in the death of the patient on the table. So some surgeons would say that, some surgeons have done that, but as far as the students are concerned and young people are concerned, it is a definite no-no. Unless you can first do a shunt. And as Dr. Richa said, that you wait minimum 3 months, some would say 6 months, she even said 9 months, and then you remove the stent, because as long as the stent is there will be no problem. You remove the stent and keep a watch on the liver functions, on the ultrasound, may have to do a repeat MRCP, and then if the biliary obstruction persists, depending on the anatomy, depending on your expertise and skill, you will try to do a biliary enteric anastomosis. And I suppose since gallbladder has already formed stones, the gallbladder will have to come out. But again, you have to approach a gallbladder with EHPVO very, very judiciously, because there are these pericholecystic collaterals. So if there is any problem in approaching the Calot's triangle, feel free or have a low threshold for doing a subtotal cholecystectomy, both on the neck side as well as on the hepatic side, because these collaterals, even after a portosystemic shunt has been done and shunt is patent, their pressure may be higher than normal veins. They are very fragile veins, and the only thing which you need to be worried in a non-portal hypertension surgery in a patient with EHPVO is bleeding. So you have to be very, very careful. Rajen, you are there. You want to say anything? Add any comment?
Yeah, I wanted to say that
Yes.
protein C, protein S, antithrombin 3, and factor 5 lead-in should be done in all patients of EHPVO.
Yeah, especially adults.
We had done a small survey, and it showed that in 80% of patients with EHPVO, in a small subgroup of 20 patients, 18 patients turned out to be positive for protein C, protein S, and antithrombin 3.
So this was an adult patient, sir?
Yes, 46.
Adult patients, because a similar study in pediatric patients from SGPGI did not show that. So that is why I was asking. This was in adult patients?
Yeah, it was in adult patients.
Okay, sir. Thank you.
Yeah, but as Dr. Richa also pointed out, any adult who presents like EHPVO, you have to keep the possibility that is it a secondary EHPVO or portal vein thrombosis, which could be because of malignancy, which could be because of cirrhosis, which could be because of inflammatory disease like chronic pancreatitis or recurrent cholangitis also.
And sir, sometimes it can be myeloproliferative disorders also. Yes. They can lead to.
Yes.
One of the comment by Dr. Jasmeet regarding the new terminology of the portosinusoidal vascular disease, PSVD. Is it same as NCPF or different? As Jasmeet, PSVD terminology is used only for NCPF, not for EHPVO. As a paper published, they have used the terminology for NCPF, not for EHPVO. And ma'am, you want to have any comments regarding PSVD?
Sorry, I am not aware of this.
Okay. Yeah, this is a new terminology which has come in to replace the term NCPF. And actually, as the experience of Dr. Piyush Sani and his team at AIMS also is that somehow the prevalence of NCPF is gradually decreasing. They are also not seeing so many cases as they used to see earlier. Nobody knows what was the etiology, whether some environmental factor has already been taken care of. The other thing which the students should know, that even if today you see it, say it is NCPF, there are now reports that these patients can also progress to chronic liver disease to the extent that requiring transplant. I think Dr. Soin's group has documented that a reasonable number of patients in whom the explanted liver was seen, it was not frank cirrhosis, it was NCPF, but they had reached a stage of end-stage liver disease requiring transplant. Thank you. Thank you, Richa. Thank you, Rajen. And thank you, everyone.
Thank you, sir.